infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Lyme disease. There's really so much we seem to not know about this in many different areas. Well, draft guidelines for the diagnosis and treatment of Lyme disease were recently issued by the Infectious Disease Society of America, or the IDSA. And these are really two big, contentious issues. And of course, there's a lot of disagreement between how the various organizations view these areas of Lyme disease. And in the past, I've often referred to this as the establishment versus the advocates. My guest today took a look at this in a recent two-part series in Forbes entitled Lyme Wars. A really good title, really good articles. So joining me today is said author and infectious disease physician, Dr. Judy Stone. Dr. Stone, welcome back to the show, ma'am.
Well, thank you so much for having me. And yes, it is a very contentious issue.
It is. Let's go ahead and start out with the major players because there may be listeners out there that may not be familiar with these acronyms. Who is IDSA, ILADS, and NICE?
Okay, well, it's tough to keep the alphabet soup straight. IDSA stands for Infectious Diseases Society of America, and they are a mainstream physician group that writes guidelines and includes many researchers. One of the issues with this group is that their guidelines are often used for guiding insurance claims and medical treatment in the hospitals. ILADS stands for the International Lyme and Associated Disease Society, and they are the rebel group, as it were, and are very patient-oriented and driven by what their patients want rather than what mainstream guidelines say. And the third group is called NICE, and that's a good acronym for them because they are playing nicely. That stands for the National Institute for Healthcare Excellence in the UK, and they're sort of in between the two U.S. groups in their stance.
Now, in the article, you say that they're not playing nice together. So, Dr. Stone, what's going on?
There's a long-standing rivalry between the two groups and contempt between the two U.S. groups. IDSA is more conservative and says that theirs is the only proper way to treat patients. The problem with that is that many patients, anywhere from 15 to 30% or so patients treated by their guidelines, continue to have a lot of symptoms. So that is where ILADS has stepped in, and they are more rogue and don't follow these guidelines. Now, the problem from my perspective is ILADS sometimes has gone to the other extreme, giving patients too much of what they want without good evidence of efficacy. The other thing that fuels this rivalry is that there have been a number of antitrust suits against IDSA and attacks that their members are biased and that they have conflict of interest because many of these groups hold laboratory interests in diagnostic tests and benefit commercially from their guidelines. NICE is in the middle of this, and they have regular treatment guidelines that are fairly standard, but they allow for more flexibility based on the patient's response to therapy and a physician's clinical judgment.
Now, you have some comments and concerns about different areas of the draft recommendations. And let me preface before I start asking the questions that you make this very clear in the article that you basically have no skin in the game other than better diagnosis and treatment for your patients. So the first question I want to ask you about is you present an issue with what a clinical diagnosis encompasses. And it's really more than just clinical diagnosis according to the guidelines.
Right. One of the things that really bothers me in the new guidelines is that IDSA insists that a Lyme diagnosis occur in a quote-unquote endemic area. And we know that Lyme has been missed. In fact, the CDC estimates there are more than 300,000 cases of Lyme last year. But these aren't picked up by mainstream claims. For example, there was a recent article where North Carolina state health departments reported 32 cases of Lyme to the CDC, but that same year there were more than 88,000 healthcare claims for that diagnosis to insurers. Similar things have happened in California and in Texas, and all three of these states are considered low-incidence states by the CDC for Lyme. So you really can't limit it to where IDSA says it's an endemic area. Two other things have changed with that. One is that we know the range of the Ixodes tick is expanding with climate change, and the tick is being found farther north and farther west than it used to previously. And as I had mentioned in one of my earlier articles, I didn't recognize my Lyme disease a number of years ago because at that time we thought that there was no Lyme in Western Maryland. So if I missed it and my physicians missed it because of that definition of an endemic area, I think the people who are less attuned to this are missing. And finally, I would add, Robert, that the definition of the endemic area is based on surveillance from local health departments. And I know in Maryland, when I've asked about this, they're not doing surveillance for ticks anymore except in military areas because it's too expensive and funding for public health has seen drastic cuts. So those are some of my concerns about it being defined as an endemic area.
Yeah. Now, the IDSA recommends against testing patients for Lyme if they have a myriad of other conditions like ALS or MS, for example. Dr. Stone, why is that, and what are your thoughts about that?
Well, I understand their perspective that Lyme is an unlikely cause of those illnesses, but they're very rigid, and there are occasional, and I would emphasize it as occasional or rare patients who have been diagnosed with a chronic medical condition that's later found to likely be due to Lyme, or that they have coexistent Lyme with it. So I would vote for some, rather than an absolute prohibition against testing, I think you need to look at the clinical picture and what the patient's risk factors are. For example, if they're a couch potato and enjoy watching TV all day and never set foot outside, they're at very low risk for having Lyme. But if somebody's an avid outdoors person or hunter, then and comes up with a weird illness, then I would test them for Lyme if that seems appropriate based on their history. The IDSA is concerned that there will be too many false positive tests. And that's true. If you do enough tests in a population where there's a low incidence of having something, you're going to turn up a number of false positives. That is a test that is positive in a patient who really doesn't have that illness. But and they're looking at it from a cost perspective in part, and from a conservation of antibiotics perspective. But patients worry about the opposite and don't want a potentially treatable diagnosis missed. So that's where some of the difference comes in. And patients also need to know that false positives can occur, especially in patients with autoimmune disease. So that's also why IDSA doesn't want random fishing trips.
Mm-hmm. Now, there's always been some disagreement concerning the time of tick bite to transmission of the Borrelia bacterium. Dr. Stone, why is this a bone of contention?
Well, the issue comes based on, again, largely on treatment. The IDSA recommends that a tick, or says that a tick should be attached for at least 36 hours based on animal models. Another source, up to date, which is a commonly used reference for physicians, says the risk of Lyme was only 25% if a tick had fed for 72 hours, and less than 1% if less, although they don't break it down into specific times. There's some other articles that say the risk is actually higher, which I hadn't known, if the tick has partially fed on someone else before. So it comes into treatment. If, similarly, they say, IDSA says, recommends prophylaxis, antibiotic prophylaxis, as a single dose of doxycycline if a tick has been attached and engorged for, I believe, 24 hours. None of this is that well established, and they don't have good data to back that up. Again, IDSA doesn't want to overtreat. Patients don't want to have something missed. And it's contentious in part because while IDSA is dogmatic about the time required to transmit infections, there are animal models that show that about 5% of ticks, nymphs of the ticks, transmit Lyme in less than 24 hours, and one study even found that it happened after only 6 hours. So nobody really knows how long it takes for the tick to be attached to transmit infection. The other finally, the last thing that IDSA doesn't say in this is that we know, and they know, that there are other tick-borne infections that can be transmitted within a few minutes. In fact, somebody in Maine died a couple of years ago from a brief tick attachment and got Powassan virus. So the message should be transmission is less likely if the tick is attached for less than 36 hours, but is not excluded.
Yeah.
I hope that makes sense.
Yeah. I mean, it does sound very rigid, and they may need to lighten things up a little bit because there are differences. The IDSA also recommends against tick testing, and Dr. Stone, you're not happy with that.
Right. I'm glad that you picked up on that. So testing, I test ticks that we find attached now. I didn't used to, but I do now because ticks can carry other things besides Lyme. And if you don't test the tick, then you don't know what to look for. So, for example, most doctors have never seen or heard about anaplasma or babesiosis, and many don't know much about Lyme. I've never seen those other infections, but I certainly know of their existence. I wouldn't be attuned to looking for problems after a patient has a tick bite if I would be less attuned if the tick weren't tested. So I think it's important to remind patients and physicians that a positive tick test for a bacteria doesn't mean that you've been infected. It means you've been exposed to something, and you should watch out for new symptoms. You know, I tell patients, mark it on a calendar, and so you know when the bite occurred, and keep that in mind. Don't panic about it. Don't do anything extra. Just note it. So positive test doesn't mean you've been infected, but a negative test rules that out. So that's why I think it's important to test the ticks.
What was IDSA's justification for that?
I'm not entirely sure. I think they, again, are trying to dissuade people from antibiotic use and from what they see as unnecessary expenses in searching for diseases that are uncommon. But I'm not sure what drives many of their decisions.
Gotcha. Okay, let's go into another.
Again, sorry, Robert. One thing I would add is that IDSA recommends a single dose of doxycycline as prophylaxis following a tick bite that's been attached for more than 24 hours. This is not based on any good evidence. On the other hand, the ILADS group will recommend treating for three weeks in the case of a tick bite before there's symptoms. So testing might actually shorten unneeded antibiotic therapy in that case.
Mm-hmm.
Go ahead.
Okay, and let's go on to Lyme testing, and which has always been an issue as long as I can remember. What is available now doesn't really cut it, according to many people. Dr. Stone, what's the problem with the current lab testing protocol?
Well, it's a very old procedure, and it's 2 stages of testing. The first is a broad screening called an ELISA test, and that misses about half the patients with early infection. In the first month or 6 weeks, it will miss about half of them. It's very inaccurate. The IDSA says that you have to have a confirmatory test, the second step of this procedure, called a Western blot test. And that's a more specific test. And again, there is disagreement between IDSA and ILADS about what to include in that testing and the accuracy of it. One of the things that there are other people who are developing new tests, and IGeneX is the most notable of them, and they have been challenged that their tests are overly sensitive and will misidentify people as having Lyme when they don't have Lyme. So there's no good standard. There is absolutely no good standard. And the thing that really surprises me to some extent is we have been able to develop rapid tests for Zika, for Ebola, and treatments for certainly treatments for Ebola. And there is so little attention paid to Lyme, although it affects so many people internationally. It's disproportionate amount of attention. I think because it's not as dramatic an illness for many.
Yeah. Now, you throughout this interview have expressed some issues with IDSA and with ELADS. In your article, you seem to show a favorable demeanor toward NICE. Can you explain that?
Well, in this case, I'm a middle-of-the-road person, and NICE seems to try to meet the needs of both groups by having pretty well-defined standards of treatment. For example, 3 weeks of antibiotic therapy initially, but then they allow for clinical judgment based on the patient's response and further information. So they don't have a particular problem with retreating patients as much as IDSA does. The place where I've had ILADS would tend to allow treatment for even longer based on the patient's symptoms. The place where I've had a problem, I think, was colored by my having been sent a patient who was dying from ALS and had been treated for a couple of years with IV antibiotics for Lyme. And I didn't think that there was any evidence that he had that. So I tend to see the extremes. One thing that I did like when I interviewed Dr. Sam Donta, who again is in between on this, he had an interesting analogy that Lyme should be treated perhaps as analogous to TB. TB patients are ill for a long period of time often before they're diagnosed, and you don't treat them with just 10 days of antibiotics. And IDSA has in fact shortened in the current guidelines has shortened their recommended treatment to 10 to 14 days. So similarly, he says, some people before they're diagnosed with Lyme have been ill for months or years and will require a longer treatment than 2 weeks or 3 weeks of therapy. So that's what I like about the NICE guidelines is they give solid recommendations, but then they say here's where clinical judgment comes into play.
And I take it you're probably not alone in feeling that way about NICE. I mean, amongst your colleagues, amongst your colleagues. I mean, because, yeah. Dr. Stone, let me go ahead and close out with this last thing. I just want to get your thoughts on a couple of issues. Lyme is the most common vector-borne disease in this country by far. However, the funding is really, really dismal. I'd like you to go ahead and address the funding issues with Lyme disease. And secondly, I'd like to get your thoughts on how media coverage is for Lyme disease.
Well, I wish I understood the funding decisions because they don't make sense to me or many other people. Johns Hopkins has estimated the costs of Lyme are up to $1.3 billion a year, not including the indirect cost or societal costs of lost wages, for example. But the NIH spends just $768 for the NIH and CDC $302 for each new case of Lyme, according to the Department of Health and Human Services. That seems very low. I think there are a couple of things at play. One is Lyme is not as dramatic as some of the illnesses that get more funding. It's not as visible. For example, there's 25 times more spending for breast cancer, which affects about the same number of people each year as Lyme does. But it's a very visible, dramatic illness when it's fully symptomatic. Lyme is a more silent killer, and so people can ignore it. Hepatitis gets more funding than Lyme, which I can understand because it's person-to-person transmitted, but it still seems disproportionate. And you may or may not have seen, but prostate cancer, which affects only about half the people as Lyme does, again gets almost 9 times as much funding as Lyme. And despite it affecting mostly older people rather than young people who are going to have the rest of their lives destroyed by this. I think the other thing at play with funding decisions, so some is whether or not an illness is dramatic. Another is whether or not it's contagious, which is why we're putting a lot of money and should be putting more towards Ebola. But you see military expenses and desires come into play, and an example of this is what I think an egregious amount of money, $31 million, that was targeted for development on an anthrax vaccine, although anthrax is not likely to be much of a problem in the U.S. And there are problems with the vaccine so far not being safe anyway. So I think some of it is looking at who's going to benefit from development of tests or treatments or vaccines that's driving the funding as well. Perhaps that's too cynical for you. And you had asked about the media coverage. Again, those are two extremes. You have the recent New York Times article, which prompted some of my outrage, with people saying, oh, my kid got Lyme and he got treated briefly and he was just fine. What's all the fuss about? And you have the other extreme of people saying that their lives have been destroyed by Lyme. And nobody is really looking at the data as much, dissecting the number of cases and the range of symptoms and the range of funding and the whole picture. It's just sensational clickbait headlines.
Mm-hmm. No, I agree with you on that for sure. All right. Well, and really good articles, and I'll link to them, the Lyme Wars series. I'll link to them in the show notes when I publish the podcast. And I want to thank you, Dr. Judy Stone, for sharing your thoughts and expertise on this really important topic.
And I thank you for having me back again. It's always interesting talking to you, Robert.
Thank you, Dr. Stone.